Hi everyone, welcome back to our journal club. Okay, I am just waiting for Dr. Sekhon to join us. She was very gracious to volunteer to do 2 videos this week. She was with us a couple weeks ago doing the antisocial personality disorder video. So tonight looks like she's about to get on. I'm just waiting for her to join us. Oh, I think she's waiting for me to invite her. There's like several different ways people can get on the video. So let me see. Okay, I just sent her the invitation. All right. By the way, while we're waiting for her to join, I just wanted to let you guys know we are like this close to having our website finalized, and that's going to be very exciting because once that's finalized, we can get registration going for our conference, and I'm just super excited. For anybody who had a blog post that you wanted to submit, feel free. I'm still taking submissions and we're working on them. Hi Zubi. And yeah, let's get going. I think she's here. So, but yeah, very close. Like I think within days, hopefully by the end of the week. So, oh,
Finally.
Hi. Hi, how are you?
I'm doing well.
Good. I was just saying that this is your second video with us, so I'm not going to go through your whole bio. I just wanted to introduce Dr. Sekhon. Am I pronouncing that correctly?
Sekhon?
No? Sekhon. Okay. So I think you told me before, but
That's
it's
fine.
been a couple weeks now.
Yeah.
She works as a correctional psychiatrist in California and is geriatric psychiatry fellowship trained. So a lot of interesting background, I think. Okay, so I didn't share the title of the article if you want to let everybody know what you're going to be going over.
Okay, great. So today we're talking about the efficacy of USMART, Ubiquitous Spaced Retrieval-based Memory Advancement and Rehab Training Program among patients with mild cognitive impairment, a randomized controlled crossover trial. This was published in 2017. This came out of the Seoul National University, South Korea, and one of their adjoining hospitals, as well as the Alzheimer's disease clinic. So basically, they took patients with MCI, starting with the background, mild cognitive impairment, described as not normal aging, yet seeing some changes, which yet do not meet criteria for dementia. Previously, there has been some research in the non-pharmacological interventions showing that there is improvement in prospective memory and the capacity to learn the face name associations. But as we know that the pharmacological interventions are not still at par, so there's more of a push to have the non-pharmacological stuff to help with memory and such. SRT, or spaced retrieval training, as the name suggests, basically is you teach a patient something. For example, an older folk, who you say that, what do you do when you get up from your walker? The answer is, I lock the brakes. And then after a while, you ask them, what do you do when you get up from the walker? Lock the brakes, lock the brakes. So it's, but you increase the time interval when you ask that question again. And it is said that it has, SRT improves learning through a combination of 4 things. It's ecologically valid, meaning it's real life scenarios. It's not, we're not just sitting and training for something that's not happening in real life. There is some priming involved that we are, you first maybe point at the brakes when you ask the patient, like, what do you do when you get up from the walker? Lock the brakes. Spacing effect. This is very important in the advertisement industry. For example, it's shown that if we see the same advertisement back to back, it won't make the same impact. Spacing effect means that, we see an advertisement a little later, it would have more of an effect. And then there's conditioning, as we know. And then there is errorless learning. Errorless learning basically means that there is no feedback. There is no capacity for the brain to learn the false information. You don't give the patient the wrong answer or say that, no, this is wrong. You just, the repetition is based on the correct answer. So those were the 4 pillars of the SRT learning. This study, the parent study was the SMART program. take out the Ubiquitous, which basically I think they made an app out of it. But before the app, it was an actual inpatient training, 24 sessions of patients with very mild to mild Alzheimer's disease. And they were able to demonstrate that there was an improvement in the memory retention spans. But it was quite tedious for the patients to come in with a caregiver, sit there for the session, then go back home, and it was quite expensive. So there was the impetus to formulate an app and see if that would be helpful. Then they talk about how IT is sort of, playing an important role. Computer-based interventions are becoming more and more popular. Computer-based SRT has been shown in patients with mild to moderate dementia to improve the face name associations. In one study, they were able to prove that the training actually helped the patients in real life, and some of them were able to retain it for 6 weeks. So they developed the USmart, the tablet form from the SMART program. And there was a pilot study done before this. It was 10 patients, and then they wanted to validate the efficacy, hence this current study. For this, they enrolled 50 patients. 50 was seen as a decent number with an expected iteration of 20%. They had the clinic that they were recruiting from was the Korean Longitudinal Study on Cognitive Aging and Dementia and the Seoul National Bundang Hospital. This was done, the recruitment was done from August 2014 to October 2014. The neuropsychiatrist diagnosed the patients with CRAD consortium to establish a registry for Alzheimer's disease in Korean. And then the neuropsychologists they performed the neuropsych assessment battery, which had a number of tests that they have listed, the 9 neuropsychological tests, along with the frontal assessment battery and the digit span test. And I want us to notice the word list, because the word list tests, the 3 of them are the primary outcome measures, so something to just keep in mind. The diagnosis of MCI was followed by what the International Working Group had said. And the International Working Group divides MCI into 2 parts.
Great news. Liberty Mutual customized.
I deliver the news around here.
Who's?
Sorry, that was me. Something just popped up.
It's okay. I think it's very interesting. All right. So the MCI diagnosis, you differentiate between the amnestic type and the non-amnestic type. And then further, these 2 are differentiated into if the amnesia or the difference is in one domain or multiple domains. However, one of the weaknesses of this study was that they did not, although when they diagnosed the patients, they were able to differentiate, but this was not a part of their analysis. They did not differentiate in the various types of MCI. And then they ascertained the presence of cognitive impairment if the participant had a score less than the -1 standard deviation of age, gender, and education adjusted norm for the Korean diaspora. And they required, and people wake up, they required that the basic ADLs be preserved. And if the IADLs are affected, they do not meet criteria for dementia. Dementia was diagnosed by DSM-4. And so that was one exclusionary criteria, and then they go into the list of exclusions, Axis 1 diagnosis, any neurological disorder that would affect cognitive function, any physical condition that would preclude regular attendance and full intervention program participation, and illiteracy. However, if you were stable in the last 3 months on antidepressants, cognitive enhancers, or sedatives, that was not an exclusionary criteria. So 3 months of stable medication was okay. And the study design was open label, single blind, which was again a weakness. It was not double blinded, randomized, controlled, 2-period crossover trial. And so basically we can go over to figure 1, that's the trial flowchart. They randomized 50 patients into 2 intervention arms. One was the USmart arm, where they would get the app to study, and then the second was usual care. They did not have a mock therapy as a control, so it was usual care. So the first 25 that were allocated to USmart, the baseline evaluation was done on week 0. After that, the evaluation was done on week 5. These were 2 interventions of 4 weeks with the washout of 2 weeks in between. So the Clinical and neuropsych characteristics were assessed on week 0, end of week 5, and then week 11. And if we look at figure 1, we see that one patient on the USmart side discontinued because of acute renal failure. On the right side, some folks were not willing to participate. However, throughout this study, no patient dropped out because of adverse effects or difficulty to learn. So I thought that was very, very interesting and important. And the patients were, these raters who studied the patients or gave them the test during these baseline and after baseline tests were blinded. And the intervention basically was that the occupational therapist would bring a tablet to the patient wherever they were and have a 30-minute session where the patient operated the app by themselves for 30 minutes. You were given a word and then asked about what the word was at 5 different intervals. So 0.75 minutes, and then you started to double it, 0.75, 1.5, 3 minutes, 6 minutes, until 12 minutes. And it started with 1 word, it would go to a maximum of 5 words. And if you got 2 sessions right in the 12 minutes, another word would be added to a maximum of 5 words. No guidance was given by the occupational therapist that provided the tablet to the patient. The tablet was taken away once the session ended, and there were 2 sessions per week. So they were pretty strict about not learning between these sessions. The primary outcome measures were the word list memory test, word list recall test, and word list recognition test. The secondary measures were the subjective memory complaint questionnaire and the geriatric depression scale to measure for mood, as well as mini mental status exam for the level of global cognition. And the SMCQ and the mini mental status exam are important because they would measure if this learning would transfer into general function, general cognitive ability, and such. The sample size, like I said earlier, they were assuming a 20% attrition, and so that they would get an 80% power to detect a 2.5 point mean difference with a standard deviation of 2.53. Eventually, if you look, they were able to analyze, if you look at figure 1, they were able to analyze 20 on the left side and then 22 on the right. So that is the second one, and then 23 and 20. So not as much attrition as they were prepared for. The week 5 and week 11 tests were carried over, last observation carried forward analyses. The unpaired t-tests were for continuous variables, and the chi-square tests were for the categorical variables. It was a linear mixed model, and it was adjusted for age, gender, education, and current cognitive enhancer use. So if we look at table 1, at baseline demographics, you can see that the patients were pretty well matched, even to the point of having the cognitive enhancer use. Their education, age, gender was very well matched, a good group, I guess, that they got. 43 completed the first intervention period, and 44, I believe, completed the second intervention period. And there were no dropouts, like I said earlier, because of the difficulty of operating the USmart application. The efficacy, if we can go to table 2. So we're looking for a p-value of less than 0.05. And if you look, the word list recall test, there was a typo in the article. They're saying WMRT under efficacy, but it is WLRT, the word list recall test. And they were able to show that in the word list recall test, the patients did have a difference when it was USmart compared to usual care, but not much difference in other areas, specifically the SMCQ and the mini mental status exam. Folks in the USmart period, 62.8% showed improvement in the WLRT score. However, only 35.7 in the usual care showed. And the secondary measures, like I said, there were not much differences. So the discussion basically that this was a bi-weekly self-administration tablet training. The patients had to train themselves. No training was provided by the occupational therapist. And And because there was no dropout because of difficulty, they're professing that having a good interface for computerized training and learning is a big deal, because that has shown that patients have improved with personal memory, information recall, name-face association, IATLs, and problematic behaviors such as eating difficulty in the past. The other important thing that they talk about that this study was able to prove was something that we talk about in learning, the generalization. It has 4 tiers. The first tier is that when we are able to transfer non-trained tasks in the same cognitive domain. For example, I'm trying to learn different words. However, if I can learn other words that I did not train for, but it's still my memory test, it's still in the same cognitive domain. It's the lowest tier. After that, it is the non-trained task that will go to some other domain, maybe my executive function that was able to be affected. After the second or multiple domains, we go to general cognitive ability, that it has improved the cognitive ability. The highest level is general function. So that our learning has translated and transferred to the function. So those are the 4 tiers. This study proved that the lowest tier, that this was transferred, which no other study has so far been able to prove. So this was a big deal for them. So the way they said that they could not establish a transfer in different domains was they could not improve the mini mental status exam, which is a measure of global cognition, and the SMCQ, which was a measure of function. The effect size could not, well, it was modest. There have been other studies. The effect size for this has, the meta-analysis showed that the computer cognitive training has ranged from 0.67 to 37.97, so it's all over the place. They're saying that maybe it's because the differences in protocols for SRT, sizes of study samples, or outcome measures, or the quality of the clinical trials. Hence, we don't have a firm number there. And the other thing that they said that patients with MCI were able to learn, or the transfer of learning took place, because in dementia, we lose our explicit memory first, and then the implicit memory. So when we are doing all these, even though SRT is helping us with implicit memory, it's sort of, you know, an unconscious thing that's going on. When we do all these tests, it is our semantic memory or explicit memory that we're testing. So we lose out on our dementia patients because it needs, these neuropsych tests need more cognitive training, and they need more explicit memory. So this might not be transferable or more obvious in our patients with dementia as it is obvious with patients with MCI. They said that this was better than using the paper pen method, or better than using the in-person trainings, because it was inexpensive, it was convenient for the patient, and despite all the hoopla about if the interface would be helpful or easy to use, they didn't find that the patients dropped out because of difficulty. So advocating for a well-designed mobile user interface. They did have several limitations. They said the study was not double-blinded. They did not have a mock therapy as control. It was usual care. The sample size was relatively small, 50 patients. They did not take into effect the subtypes or causes of MCI, like we talked about, the amnestic, non-amnestic type. The duration of treatment was too short to test the efficacy on general cognition or function. And the differences in outcome measures might have been attenuated because the difference was so short. So they were thinking that maybe the learning carried over. And they did not evaluate how long the improvement lasted. So overall, they were able to conclude that this tablet-based self-training mode, which is called the SRT, transferred at the lowest level of the generalization, which is the untrained task in the same domain. And despite the fact that there was no control therapy or mock therapy, there was a good result that the USmart showed improvement in the word list recall test. And because there were no dropouts because of difficulty, no adverse effects, so they're advocating for more. Hopefully there will be a bigger study coming out. So I think we've learned that in MCI, because implicit memory is more, we're able to test more of implicit memory in our neuropsych batteries. This was an easier task to prove. Yep.
Okay.
So,
Well, thanks.
Yeah.
Did you say that they have an app?
Yeah,
Or
this
they
is.
developed an app?
I tried to look for it, and there are all kinds of apps out there.
Okay.
But this is an app. It was on an iPad. Yeah, it's an app-based training.
So do you think is it something that we can recommend to patients, or they only used it for this study?
I could not find it on the App Store.
I see. Okay.
Yeah, so this was more of their study, and it was because it was Korean.
Okay.
So I don't think
that would make it harder.
Yeah.
For our patients here.
Yeah.
Okay. Well, thank you. I don't see any questions. As always, people can always add questions later if you have them or think of them. But thank you. We will be back on Wednesday covering. Do you remember? It's the Alzheimer's.
It's aerobic exercise.
Exercise.
150 minutes.
Yeah, which is a lot of exercise. I was like, that's 30 minutes. I did the math, 30 minutes, 5 times a day. I was like, if I could do that much exercise, that would be amazing. But yeah, no, that'll be a good, I'm always interested in hearing about how exercise can help with, psychiatric things. So, all right. Well, thank you. And everybody, we will see you guys on Wednesday.
Okay, bye.
Okay, take care. Bye.